components of our plan. Good to see you as well, sir. Thank you.
The floor is yours, sir.
Thank you. Good evening, everyone. It's been a while, and it's great to be in my home county for a change. I'd like to just take a second to thank you for the opportunity to spend a little time with you today to update you on what's going on at Shore Regional Health, and more importantly, to answer any questions you might have about the status of our hospital here in the five-county region. If you don't mind, I'd like to start with an update on our service delivery plan. That plan, as you'll recall, has been in the works for about 18 months now, and really was the product of a change in the healthcare industry in the state of Maryland, a complete overhaul of the waiver, which is the document that we operate under as the regulatory agency in Maryland, and really an attempt at looking proactively at the care that we provide in our five-county region and anticipate what's needed 5+ years from now and develop a service plan around those objectives. As I mentioned, we've been working on that plan for about 18 months now, and if you had a chance to see the Star Democrat on Sunday morning, you saw the article above the fold, which identified pretty concisely some of the major components of our plan. I'd just like to reiterate that that document that was published was a confidential document. It's a work in progress document. It's actually a draft that has not been approved by our board of directors yet. But my intent today is to share with you kind of where we are in that process and also just clearly define kind of what our end game is with that document. And the end game is really twofold. It's really to define the services that our region needs for the future of the healthcare industry that we're experiencing. The services that will be reflected in 5 counties of Maryland's mid-shore. And looking at it from the perspective of 5 different major constituents: primary care, medical specialties, surgical specialties, behavioral health, and cancer. You can put pretty much all of the care and services that we provide into one of those buckets, if you will. And by looking at them independently and throughout the 5-county region, we're able to very clearly articulate what exists today, what's needed in the future, and how we will prioritize that gap between what's needed and what exists today. And that's the work that we've been conducting in the form of committees that Shore Regional Health has pulled together with a variety of constituents in those committees, from physicians to team members to people outside of our system who are experts in the areas that I mentioned above. So I'm pleased to report that the work in progress that has taken place over the last 18 months has resulted in a document that we believe accurately reflects what the future may look like in healthcare and what some of our needs may be specifically here on the shore. Now that we've got a draft document that we've created, we are in the process of going through the approval process at Shore Regional Health with that document. So as I mentioned, there's 3 approval processes that need to take place. The first is the committee structure that originally was formed to pull this document together. Independent committees met, they put their reports together, collated it into one report, and that is the service delivery plan that I'm speaking of. That initial committee has reviewed and approved that document. The next step forward is to go to the strategic planning committee of our board. That document, that committee was assigned to task this council to get this project done. And we are in the process of reviewing that document now at our strategic planning committee level. One of the things we're doing at that level that was different from when that original document was prepared is we're overlaying some very important components to it that didn't exist previously. First and foremost is the cost of that plan. We didn't want to hamstring our groups by saying you can't afford to do this, you only have this much money to work with, but we took the time to say, tell us what you think the future needs, and we'll overlay the cost after that, and that's what we've done since then. And then in addition to that, we really wanted to expound a little bit more on the transportation barriers that exist in 5-county mid-shore regions like ours, who are very geographically dispersed with limited transportation means for much of our community. So we interjected that into the plan as well, and that's why it's taking a little longer for review and scrutiny at the strategic planning committee level. So we expect that they've had a few meetings already, and they will get to the point of ultimately finally voting on that document and hopefully approving the contents of that document. At which point then it will go to our board of directors for final review. In the midst of all of this, we've also received community input. We've held a number of listening sessions throughout the community and got really important information from our community's perspective and incorporated that into our document as well for the strategic planning committee and board to assess. So I'm pleased to say it's working its way through the process. We anticipate, if things go to plan, that we'll likely have this service delivery plan approved by our board, likely in the May-June timeframe. I give you that as a high level because our board is going to take all the time it needs to review and scrutinize and debate the document until it's sure that it's worthy of a vote. But we're anticipating somewhere in the May to June timeframe. And I think what's important about that document is that will serve as the roadmap for our future efforts and our future strategies of how we're going to tackle healthcare in this region that we are experiencing over the next 5+ years. And what's been interesting as we've gone through this process is that the state of Maryland and the legislature has weighed in on rural health care very specifically and has targeted the 5 counties of the Mid-Shore with some specific legislation. They actually adopted amendments to SB 707, which is a freestanding medical facility bill. But the basic amendment that was attached acknowledged that there are issues with the way the state runs health care with regard to vulnerable rural counties like the 5 counties of the Mid-Shore. The waiver, even with all of its best intentions, we feel might not have addressed all the needs of rural Maryland. And so to the state's credit, they have defined a study period that they want to embark on that will look at rural Maryland and identify if there's ways that the state of Maryland can support rural Maryland so that acute care facilities in those areas can be sustained. Because without the state study and without the state support, it's likely that acute care hospitals in rural Maryland will continue to struggle and likely have to look at alternative options to sustain themselves and the communities they serve. So, to their credit and to our full support, the state has identified an amendment in 707 that says that they will conduct a study on rural Maryland and hospitals within the zones, specifically targeting the 5 counties of Maryland. That study will be initiated likely in July of this year. And it does have an end date in the bill that says it needs to be concluded by October of 2017. And again, we fully support this because we have 3 hospitals in the 5 counties that they're designated as rural Maryland. So we will be at the table during the discussions and we will support the state's efforts to try to address some of the ways that they can help. And just as an example, some of the things that we're likely to talk very specifically about are transportation, recruitment and retention of physicians, access to primary care, technology. Those kinds of things are challenges on the Mid-Shore given our population density and given our geography, and the state's going to take a hard look and see if there's a way they can help. So again, we fully support that and are committed to being involved in that. So we will continue to seek board approval for our service delivery plan, all the while we intend to get engaged in this study. And I think it's through those 2 parallel tracks that at the end of the day, we will have a very clear roadmap of how we're going to address rural Maryland and healthcare in rural Maryland with regard to the services that we can provide here. Now, one other question that our 5-year strategic plan did not address was the need for the replacement hospital here in Easton. And we promised that as part of the service delivery plan, we were going to look at and try to answer that question as well. And I'm pleased to say that as we've gone through this process, we also intend to seek the Shore Regional Health Board approval, as well as the University of Maryland Medical System's approval for the replacement hospital in Easton. Those approvals by a Shore Regional Health Board and the UMS Board would allow us to update our existing docketed CON that resides currently with the Maryland Healthcare Commission and update that document so that it's relevant to our current state. Now, some of the things that we're going to need to update on the CON application that's currently filed is the cost of the project. We recognize that over the last few years, the cost has gone up. Its cost of living has gone up with mostly everything else, so we'll need to update the cost of the project. We're also going to need to update the application based on some of the changes that have occurred since when we originally filed the application. And one example of that change is we recently received approval for PCI testing on the Shore. And I'll get into a little bit more detail about that in a minute, but that's a new service that we're offering here on the Shore that did not exist when we filed the original application. That will be a regional program, but that will be centered and housed out of the new hospital here in Easton. So we'll need to update that application for that information. We expect that if we can receive the approvals that we are seeking, that update of our application will take place in September of this year. And once that application is docketed, then it's up to the Maryland Healthcare Commission and the Health Services Cost Review Commission to evaluate our application, ask questions about it and get clarity about what our intent is, and then ultimately weigh in on that approval process. It's likely, given our current environment, that process, that once that application is docketed and updated, it could take up to 12 months, if not a little longer, for the state to weigh in on that final decision. But our intent at this point is to seek board approvals and update that application for a September 16 filing.
Can I ask a question there?
Sure.
You said 3 times board approval to build a new hospital. I thought that has been a given for years, that that's what you wanted, and that all we were waiting for was the CON process, which has been delayed. But I'm a little troubled when I hear that you have this plan lead nicely into the Star Democrat, but you've said that you need board approval for this new hospital.
Yes, since the original application was filed, we pulled this council together to look at our system and evaluate our system. And since then, though, we've had to address the changes in our industry and also address the potential need for the application and for the replacement hospital. It's still needed to get re-reviewed. We've got a new set of board members. We have a new service delivery plan, and all of that needs to be reevaluated by our board, and the changes and the cost associated with this project.
But every time we've had a conversation, there was not a question, it was when, not if, and no, it's never, I mean, this is news terminology here to say it needs board approval to build a new hospital, so.
We do. It was received during the original docketed application. If that application needs to be updated, our board is going to weigh in on that final decision before we officially refile that application. Now, it's my sincere intent and hope that the information that we present to our board will be acceptable to our new board, and they'll allow us to update that application and file it. But I don't want to speak on behalf of our board until they have that discussion and vote. And again, that will take place over the next few months.
Is this the local board on the Eastern Shore, or is this the UMS board that's statewide?
It's both. It's both the local board here at Shore as well as the UMS board. Now, I'll remind the council that the UMS board has identified a 5-year capital plan that includes our replacement hospital for Easton, and the monies associated with that replacement hospital are included in that 5-year plan today. So they are fully aware of our study, they're fully aware of our plan and our timeline, and have allocated that money pending approval from that board.
Does the 5-year plan allocate certain monies each year separately, or is it a lump sum?
It's a lump sum.
And when is the lump sum currently slated to enter into the budget?
I'm not completely sure, but I believe it's fiscal 18.
18.
So that would allow for our fiscal year 17, as an example, starts July 1 of this year.
Okay.
So fiscal 18 would be July 1 of next year, and that would allow time for the docket to be updated, for the application to be updated, and for that likely year review by the MHCC.
Okay. And I think the last time you came in front of us, or maybe the time before, I can't remember, you indicated that the hospital made a profit and was not in the red, which is a good thing. It was
Yes.
a modest profit of about 2%, as I recall.
That's right.
Do you have updated figures? Because I know that the CON was conditioned on the hospital turning a profit, or at least justifying its existence financially, which was part of the reason why it went into hold mode, because of all the changes in healthcare.
That's exactly right. So it went into hold mode because of the changes in healthcare that resulted in us not being profitable. Since that time, we have turned a profit in each of the years since then, and we anticipate for the end of fiscal 16, which ends on June 30th of this year, that we will remain profitable at Shore Regional Health, and likely to the tune of somewhere between 2.5% and 3% operating margin. And that, you're absolutely right, sir. The intent is that we do maintain a profitable organization, and UMS maintains a profitable organization in order for us to proceed with the application. And both of those conditions are being met.
Okay.
So we're still on the same, I believe we're on the same time frame. There's a pre-filing or a letter of intent you have to file with MHCC before the actual CON is filed, correct? Is there?
We learned from MHCC that it's likely that since the application is currently docketed, we might not need that July letter of intent process.
Okay.
I think that's just designated for new applications.
Oh,
Since
very
ours is an existing updated application, we won't have to go through that process.
Okay, so we're just focusing on September of 16 to refile the CON.
Absolutely, and members of my team are tightening that up as we speak.
And could you let us know if for any reason that $5 million or whatever that amount of money is slated for 2018 slips back a year or 2 years, if that moves in the budget,
The 5 million, I'm sorry.
or whatever the monies
250
are that are allocated for
From
the
University of
starting of the hospital,
Okay,
construction, I assume, or
Absolutely.
or architectural services or whatever,
absolutely,
it'd be nice for us to know if that moves.
absolutely.
Because that affects the sewer line that we have to allocate money for, and that's a huge ticket item for us. So the more time we have to plan, obviously there was some talk about putting the pipe in the ground ahead of time, but then we found out technically the technology doesn't allow for it to be in the ground if it's not being used. So we need to make sure that we time that properly. There was one other question. You said something about the state and them helping. Are you talking about being hopeful that they are going to allocate money to help subsidize the hospital?
Yes, and I think it's more likely that those subsidies will occur in our outlying facilities in Cambridge and Chestertown, and it's really because of the proximity from those hospitals to Easton, as well as the economic impact that the hospitals have in those communities and the viability of the hospital as it relates to the community itself. So I think those circumstances in those outlying areas of Cambridge and Chestertown are more likely to get a higher level of support just because of the geography and the vulnerabilities that they're experiencing there.
Does UMS receive anything right now, support-wise?
No, at this point, Shore Regional and UMS gets the same rate adjustment year after year as the rest of the state does. But I think the state has recognized that there's an opportunity to address some of these rural areas who are struggling with maintaining profitability, recruiting and retaining physicians, which is a big condition of keeping our hospital open, and coming up with creative ways to help resolve that issue.
Helping pay for med school, maybe?
Or at least loan forgiveness, at least, absolutely. Tax relief, inducements to coming to rural areas, absolutely. Those are things that have worked in other parts of the country, and I think Maryland is going to take a hard look at that. And again, we applaud the study because without it, we were really looking at other alternative options that I think may not be necessary now.
Yeah, Mr. Stamp is not here, but he and I spoke with you regarding the number of code yellows that, not just here in Talbot County, I guess across the state, where emergency vehicles are being diverted to other hospitals in their region. Can you talk a little bit about how freestanding medical facilities or urgent care facilities will help in reducing those code yellows here in Talbot County?
Absolutely. The code yellow or code red alerts are prevalent throughout the state of Maryland. Hospitals are challenged to keep their doors open and challenged to absorb the influx of patients coming into their emergency department and those that need to be admitted. Some of the strategies that hospitals like ours try to initiate revolve around how do you keep patients getting access at the appropriate times at the appropriate locations. That way, the emergency department is not their default primary care. And some of the ways that you can do that include things like adding more primary care providers to your region. And not just physician providers, but now nurse practitioners and other types of providers that can expand the coverage and provide each of our community members with a primary care provider. If you can do that and you're being seen by your primary care provider once or twice a year, that will go a long way to address some of those chronic conditions that patients are using their emergency department for. Because the primary care provider are going to connect you with those resources and then monitor your progress to make sure you're doing what needs to be done. So that's one strategy. Other strategies include things like urgent care centers. Urgent care centers are usually best used when it's after hours. Even if you have a primary care provider, they're closed at usually 5 o'clock in the afternoon or closed on weekends, so you don't have access. And in some cases, let's say you cut yourself and you need stitches. That's not necessarily an emergency department visit, but without an urgent care type of setup, that's your default location. So patients are going to the emergency room. Well, we intend and are in the process of instituting 2 urgent care facilities in our region to get into that line of business. The first urgent care center we expect to open in May of this year, and that will be in the town of Denton in Caroline County. We chose Denton and Caroline County primarily because we have a convenient care center there today. It's kind of an urgent care light, if you will. We wanted to test it to see if it would be used by the community, because the community in Caroline County is using the Easton ER as their primary care to a large extent. So by creating this convenient care center, patients have access to after-hours and weekend care. And what we found is that they're using it to the tune of 4,000, 5,000 plus visits a year. So that's why we started it in Denton. And that's going to open in May. And again, that will help absorb a lot of those patients who are still going to Easton's ER and still causing alert status when the volume of patient influxes gets too high. But that's going to initiate, I think, a lot of support for those Caroline County patients. Now, the second of 2 urgent care facilities that we expect to open is going to be here in Easton. We have defined the location. It's going to be near the Harris Teeter, over near the new developments. And our timeline to open that center is likely the end of August, early September. We're hoping to get it open before Labor Day weekend. That, again, will help alleviate a lot of ER visits that exist in Easton for patients that don't need ER visits and can be treated in that center. So primary care with physicians and nurse practitioners, adding them, and we've added a few to our staff, urgent care centers, and also improving the efficiency of our patients who get admitted. A lot of times ERs are backed up because we can't get the patients upstairs to the beds where they need to be kept. So by looking at the flow and maximizing the efficiency of those patients who get transported, minimizing the time it takes to get that patient upstairs is also going to help relieve the backlog of patients in the ED. So those are some strategies that we're working on, and we fully expect that they will have an impact on the ER. Now, they're not going to eliminate yellow and red alert,
Right.
but they will certainly have an impact.
Help mitigate it.
Absolutely.
There was also a bill, and I don't know how that bill fared in the session, allowing those emergency units to respond or take those patients to those urgent care units. Do you know that, well, of course you would know, if that bill was successful or where that bill is?
I think that is likely still a work in progress. I'm not aware that that decision has been made to allow EMS providers to take patients to urgent care. I don't think that's been approved by anyone yet, not yet. But I do think that over time, when we prove that it's much more effective for the EMS providers in each of the counties that we serve, it's much more effective for the patients and for the healthcare system to be able to transport non-emergency patients to those types of facilities. We're going to get behind that bill once we prove that it's safe and support that type of legislation.
I'm sure if it had passed, we would have heard from Mr. Stamp by now, so probably he's not here, so.
It's not that I'm aware of, sorry.
What about the part about, talk about the observation stays? If a hospital, if it gets to a point where they can't be open as a bedded facility where you would stay for a week, but they still have the emergency room where you can stay for 48 or 72 hours, how does that play into that? And does that help alleviate some of the citizens' worries about their local hospital? Is that a compromise?
It hasn't been in the regions that I've spoken to so far. Community members want full-service hospitals, which include observation beds and admitted beds. But the freestanding medical facility legislation that was just passed unanimously by both the House and Senate at the state legislation allows for acute care hospitals to convert themselves to freestanding medical facilities without going through a CON process. And with that, then, that will allow them to have observation beds in those facilities, full service ERs, 24/7, 365, with observation beds, but not inpatient beds. If a patient is in observation and needs to be admitted, that patient would be transferred then to another facility. There are parts of our state of Maryland that have recognized that that's a valuable tool for them to use, and that tool can be applied now to their specific region. We have opted through legislation, through this SB 707, that carves out Chestertown from using that option at this point in time until March of 2020. Now, we have extended that until March of 2022 to demonstrate our commitment to providing acute care facility access to the Chestertown region. So that tool is available. It does provide for observation beds and not inpatient beds. It will be used by other parts of the state, I believe, in the very near future. But we have carved it out in lieu of the study in hopes that the study would address some of the deficiencies that we've got and allow us to keep them open as acute care facilities.
On another note, customer service is always something that in your line of work and in our line of work, you always try to make sure you give the customer the best quality of service possible. there have always been these whispers and innuendos about the quality or the customer service here at the hospital. Can you talk a little bit about how you're addressing customer service now and in the future to make sure that your customers are getting the best quality of care, not just from their doctors, but from coming in, aesthetics, and looking at the place and the whole experience?
Absolutely. So my personal opinion is that there's nothing more important than the patient experience. And when the patient uses our services from one end of the spectrum to the other, that they have the best patient experience possible. That's the vision that I have and that we have as an organization, and we are working hard to put that into place, what we like to say, every patient, every encounter, every day, so that regardless of where they are in their system, they achieve that level of excellence. The ways that we try to do that, and one key way that we're really shifting our focus on how we're going to accomplish that, is that hospitals like ours have always operated under the belief that we know what the patient experience needs to look like. And we define that, and we build the processes around that definition. Well, what we're learning very quickly is that we're not always right, and that oftentimes it's the patient's perception of that care that is critical to their experience. So we need to take a deeper dive and learn more about the patient's perception of their care and what's important to them instead of what's important to us, and build the process and solution around those things. So as an example, patient's preference may be that when I need to see my specialist, I need to be able to see them within 2 or 3 days of care. If you ask me as a hospital administrator, knowing what resources we're trying to work with, I'd say in some specialists, we're lucky to get you in a week to 2 weeks in advance, but that's not good enough for our patients. So how do we change the experience so that their perceptions are being met? And how do we do it? So that's the key focus, I think, that our organization is trying to work towards. And we're asking our patients about that information. We're getting valuable feedback about what's important to them. And we're building the processes and solutions around those conversations.
And I'm going to assume within the service delivery plan, customer service is weaved through each one of these disciplines so that we're certainly maximizing the customer service experience, the customer experience through each of these disciplines.
Absolutely. It has to be, because we could provide all of the services that are needed in every corner of our 5-county region. But if it's not high quality, patient-centered experiences, then they're going to go somewhere else. And we've just wasted our time. So that's why it's paramount in my mind and vision as the CEO of the system, and it's my responsibility to indoctrinate that into the rest of our organization. And we have started to do that, and I think it's starting to take hold in many places of our organization, and we'll continue to work towards making that happen everywhere. Again, back to every patient, every encounter, every day.
How are the staff levels at this point? There have been some layoffs. Where are we at that?
What we have done effectively, I think, is benchmark our organization to staffing standards. So there are national organizations that say for a hospital your size and the type of work that you do, this is the staffing level that you should be at for all of the departments in your organization. We brought in a company to help us do that, and they looked at a number of things. They looked at our size, our scope of responsibilities, and we asked them to put us at the 50th percentile, right in the middle. We didn't want to be too lean and run our staff ragged. We also didn't want to be too heavy and have too much staff. So the 50th percentile is a good target to do that. We brought an organization in. They've assessed us at every department level in our organization, established those standards, and now we are staffing to those standards, and more importantly, budgeting future budgets, like Budget 17, which starts on July 1, to those standards. So I'm pleased to say that while we needed to adjust them when we got the results back, we have maintained our current level of staffing.
So when they
and
told
standards.
you, that's when some people had to be let go?
That's when we identified that we needed to get to standard, yes. And in many cases, though, what we did as an organization is we said, let's not fill vacancies during this process. We know that there will be departments that are overstaffed or have positions that have been defined for them that are more than what's needed. So if someone left, we didn't fill that position because we knew that it's likely that we were going to have to take it away at some point in time if they're not meeting the standard, and we didn't want to take it away with somebody in that position.
Were there any areas where we didn't have enough?
Yes, there were some areas actually where we staffed too lean. One example is our pharmacy departments, where we looked at the standard of what was staffed and what we were currently providing, and they were more in the 25 to 35% staffing standard as opposed to that 50th. So we evaluated that and talked to the management team that runs those departments and maybe slowly tweak them up to the 50th percentile. But those are things that good organizations do for a couple of reasons. They make sure that they're running a lean and efficient organization, but they also ensure that the work that's being done is appropriate given the size of the organization and the scope we have. And that really helps us prevent those ebbs and flows of layoffs and new hires and layoffs and new hires that most organizations experience year after year. So that's our strategy. We've employed it at this point. We're going to continue to execute on it in budget 17.
All right, one more question on that. So we have a higher age population here in Talbot County compared to, a hospital someplace else, and they might require a little bit more help with things. So did that company take that into consideration, that we're dealing with maybe aging problems, reasons that they're in the hospital are because, they broke a hip or they're elderly as opposed to, falling off a roof or whatever?
Right. Yes. Not so much the original company that came in to do our benchmarking for us. They didn't use age cohort of your population as one of the factors. They just basically looked at productivity, number of people, number of services, time it takes to do that service. But we as an organization have that responsibility to include that in our assessment. We recognize that there are standards, and then there are also the patient experience and the perception of patient experience, as well as retention of our staff. So it's a balance between those standards and what's really going to result in great patient care and keeping our good staff as part of our organization. And one example where we found that out is that we may need to tweak up the number of nursing techs that we've got on our nursing units, because they are very instrumental in providing the care that's necessary on an ongoing basis while the nurse is providing more direct care periodically throughout the day. So it's through conversations with our leadership team to assess these benchmarks on a regular basis, flex them conservatively, but get them to a point where they're appropriate for the patient care needs of our organization. So that's the little gray area that I will allow as part of what we're trying to accomplish here.
One other thing you may want to consider between now and 2018, and I know that the University of Maryland has more clout with the state officials than we do down at this end. But when we lost the $2.8 million worth of sewer grant monies that we had obtained, it would be nice if we could work on replacing those monies with some state funding, if that's possible. And we would need your help to do that and to run that up the flagpole. It's not that we can't do it. If you were to say we're breaking ground on the hospital next year, we will find the money to run the sewer line. But I think in all fairness to the citizens, if the hospital could work on that issue for us to find the $2.8 million that we lost, or maybe have it reestablished when we need it through the state, that would go a long way to alleviating our strain on the financial side, because it wasn't because we did anything to lose that money. We had it lined up and ready to go, and we lost it because we couldn't use it.
I think the state funding was a little less than that, but I think it was around $1 million from the state.
Well, it was, I'm sorry, yeah, but in all, it's about $2.6, $2.8 million that we lost between the state money and the EDA money. So if there was some other fountain of money somewhere, and you all could help us get that back, that would sure help us.
That's a well-received recommendation. And one of the things that I think that I've benefited from greatly over the last few years is the opportunity to meet with Corey and our council president on a regular basis. He and I and the mayor sit down and talk about the state of the state and really make sure that we're keeping open lines of communication between our organization and the council. And as we continue to do that, and as we continue to get updates on where we are with our service delivery plan, with our replacement hospital timeline, these are instrumental conversations that we'll need to have to help make sure that both of our needs are being met throughout this process. So, Corey, I look forward to continuing the dialogue with you on a regular basis and continuing these very specific types of ways that we can help each other succeed.
Just following up on Dirk's point, when I mentioned we were thinking about putting the sewer line in and that we couldn't because of the technology, the way that works, that was so that we could have used the $2.5 or $3 million, but there was no way to use that money. And it would have been a little bit of a gamble for us since we really don't have anything totally signed on the dotted line other than the property itself. But, we obviously here in Talbot County want the hospital here in Talbot County, and there's an economic benefit to doing that. But it is on the taxpayers' back of Talbot County for a regional hospital that, 4 or 5 counties, come here, and we did agree many moons ago to put in that sewer line, but would be more than nice to try to get some assistance with that, and hopefully the state will view it that way, that they're assisting because it's serving more than just one county.
Points heard and well taken, and I'll do my best to support that personally, as well as bring the forces of the University of Maryland medical system to bear as well.
Thank you.
If I could, I just want to make sure that I'm being very clear with regard to the replacement hospital. The application that's on file is for a replacement hospital for Easton. It will not include inpatient beds from Chestertown or Cambridge in the form of a regional medical center. The study and the moratorium that we've put, especially in Chestertown, will address those over time. And it's our sincere hope that they will be addressed over time through the state's support. But the replacement hospital will not include additional beds being migrated from our outlying facilities in Cambridge and Chestertown as part of the application.
Is it still slated to be about a 100-bed hospital?
That is what we're still trying to calculate at this point in time. That's part of our process that we're going through. What are the trends in admissions nationally, state, locally, and what are the efforts that the state wants us to embark upon in reducing admissions, which is a very concerted effort at the state level. So how does that fit into our calculations and into our projections? And as we fine-tune that, I'll certainly communicate that on a regular basis.
So when you do your calculations, then you have the emergency services that are going to have a new place in Denton and have a new place in Easton to relieve this over here. That will make determinations on some of the new hospital decisions that you have to make.
They will likely not have an impact on the application and the number of beds that we submit to the state. I think the state would want to see evidence of success for those types of measures from previous years before they would count them and legitimize a reduction in beds because of those additional features. I think they would really want to see us demonstrate success there before they would interject that into the possible calculation.
But they should have an impact on the number of emergency room visits.
Absolutely.
Right, but sometimes you can't, the emergency room goes into a code yellow or code red because there's not enough beds to move people to. And yet we're still planning to build a hospital with a significantly lesser amount of beds. It just doesn't work in my head.
I haven't stated that, and I think we still have to do work to find out exactly.
How many do we have here, 180 beds?
We are licensed for 100, I believe, we have the capacity for 182 patients, but we are not licensed for that number of beds. I believe we're licensed for somewhere between 130 and 135, and that changes on a yearly basis.
Right, but 130 or so is more than 100, and we are, again, the emergency room, we're going to alleviate that with some of the freestanding places, but it just still tells me that you can't.
Well, that was my point of if, all this is going to be online in, 3 or 4 months with the new little emergency places. In 17, it looks like to me that study will show a little bit more what impact that's going to say to this hospital and the surrounding.
Yeah, I think the patients that will go to those facilities won't be admitted.
Right.
Typically, those are not admitted patients. Those are patients who would have been treated in their primary care office, and it just wasn't.
What makes me a little nervous, do you want to get into that type of business because it's a little bit faster and it's a little bit more cheaper? So that's a little bit of concern to me.
It is a part of our continuum of care, though, that our patients really need, because without it, they are going to the emergency department, likely unnecessarily.
Yeah, I'm with you.
Yep.
And I want to say, personally to you, that I want to thank you for, as busy as you are, also availing yourself to a number of other boards and committees, being part of the BRCOC and being a part of the LDAC, so to lend your voice to those committees. Not only does this council sit as the legislative arm and the executive arm of the county, but we also sit as the Board of Health. So we are very much interested in what's happening at your regional hospital. And we're kind of hitched our wagon to you, so to speak. So we're very much concerned to your success and to your outreach into the community and to your commitment to a higher standard of customer service. Because I think if you do well, that means our citizens will do well if you're giving them a level of care. And as the Board of Health and as the legislative arm and as the executive arm, we're making sure that our citizens are getting the best that they can possibly get out of your out of your unit. So thank you for just being involved in those other committees, looking at substance abuse and looking at other health issues here in the county, and of course of all your other work that you have to do. So
You're very welcome.